So coming up next, we have Dr. Simon Fitzgerald, one of our trauma surgeons here, giving us a talk on surgical airway. Dr. Fitzgerald was born in the Bronx and raised in Baltimore, educated in Maryland, Havana, and Brooklyn. He earned his MD and MPH from downstate and trained in general surgery at Mount Sinai School of Medicine in Manhattan, as well as did his surgical critical care training at Johns Hopkins Hospital. During his fellowship, he became an ambassador for the Baltimore ceasefire movement and helped organize quarterly weekend ceasefires in Baltimore. He is currently a trauma surgeon and intensivist at Kings County Hospital, where he is the director of trauma education and surgical liaison for the Kings Against Violence initiative. His recent work includes telemedicine support for trauma teams in Gaza, which he has described in a news article he authored for The Guardian and in a forthcoming manuscript accepted for publication by The Lancet. Okay. So please welcome Dr. Fitzgerald.
Thanks. It's been a while since I've been in this room. I like the centrifugal force that sent you out of the back of the room. This is the third iteration of this talk I've given this month. The first was to surgical residents, the second was to paramedics and EMTs, and now to the resident group. So forgive me if some stuff seems like it's not quite targeted for you. We'll try to make it as relevant as possible. We'll just get into it. So I want to focus on airway and trauma.
What that is outright said no.
There may be people in the room who have intubated more than me. And that's not necessarily where my expertise is, but I want us to think about the patients that we co-manage, think about the airway. And whenever we're thinking about trauma patients, you start in the beginning. When I was a student, I remember being impressed by how much people had to think about what to do in trauma. And someone corrected me and said, the purpose of protocols in trauma is to not think as much as possible until you're forced to think. So things happen like they're supposed to, like clockwork, without too much thinking getting in the way. So whenever we take care of a trauma patient, right, we have to do the trauma survey. Often we talk about ABCs, although in the literature now, people are talking about CAB, focusing on circulation, especially in penetrating trauma when bleeding is the main problem. But really all these things are happening not necessarily in sequence, but in series, that we have a team that are doing things at the same time, right? And I just want to think about the ABCs all at once together, and then we'll focus on airway a bit, right? But when a patient comes in, right, you guys were probably taught ATLS, the first thing you do, you talk to them, can they phonate? Okay, then you think they're moving air pretty good. You don't hear any sounds of distress. And that's what we're trying to assess. Are they phonating or otherwise spontaneously breathing without any sign of obstruction? Do we need to support them in any way? And do we need to take any measures to either definitively or temporarily secure the airway, right? And that B for breathing, we're thinking about the chest, we're thinking about oxygenation, and we'll get to it. But for me, the biggest thing here is like tension, pneumothorax especially. Is there something we have to do right now before we move on to things to free up the chest and allow the patient to be safe and stable for the rest of our exam? And circulation, right, has to basically do largely with hemorrhage, although there can also be, thrombotic events that we'll notice when we do a pulse exam. But if you ever listen to me when I ask my residents to go through the primary survey with me, the circulatory exam, I feel like the way I teach it is different than anyone else I've seen teach it. Right? Everyone says, yeah, you want to check the pulses, you want to assess for shock, basically. But I want to know, right, where could this patient exsanguinate? And is there any evidence of exsanguination, right? Are they actively bleeding from a scalp laceration? As part of your circulatory exam, we can't move on until we get at least temporary hemostasis. Your chest exam, is there a sign that they're massively exsanguinating into their chest? Abdominal exam, same thing. Pelvic, retroperitoneal exam, or long bone, right? I want to hear you check through that list and tell me if there's any sign of life-threatening exsanguination in those compartments or on the floor. And also, before we move on, we need IV access. That's part of circulation in your trauma exam. And until we do that, we haven't completed the primary survey. And we'll get to the caveats and thinking about it, I think, with our cases. right? This is basically what we just said. And to simplify this, the A, I'm thinking about oxygenation and ventilation. That's what we need to do. B, is there a tension pneumothorax or something else that won't allow the patient to breathe and ventilate? And C, we need to stop the bleed and we need to resuscitate the patient, right? To me, that's boiling down the simplicity, right? There's ways of doing things, but these are the questions I'm asking myself and the actions I want us to take basically in the primary trauma survey. This is going to be, I'm starting to get a little bit redundant, but basically oxygenate and ventilate, and how are we going to do that? Sometimes it's temporary and sometimes it's definitive, and we'll get into thinking about when we need to do what in this talk. Tension pneumothorax, I highlighted this especially for the EMS people, because in the field, right, basically for field management, especially penetrating trauma, I want, there's data that shows that patients, for example, in Philadelphia, where there's a culture and a history of police transport because they so underfunded the EMS system for so long, that there's a culture of police throwing shooting victims in the back of their squad car and rushing to the hospital. And you know what? They have better outcomes than waiting for EMS. So the point is, there's very few things that first responders can do besides putting them in the bus and getting them to the hospital. And one of them is relieving a tension pneumothorax. And that also goes for us. One of the things that we need to recognize and take care of in the ED is tension pneumothorax. All right, this is redundant. Okay, so let's get to the airway stuff. Let's see, do people read in the audience here? Or is there a culture of me talking at you? Which one is better? But let's take this patient. Okay, we have not uncommon. We saw probably a couple of these the other day. A young, healthy guy shot in the abdomen, who was brought in basically in shock, tachycardic, borderline pressure, mentation is poor, abdomen is tender, shallow respirations. Anyone smart and brave want to, and we say the GCS here is 8. Anyone want to think with us, how are we going to manage the airways initially in our initial interactions with this patient? What is going to be our priorities in managing this patient? So if we're doing ABC, what's A? How are we going to manage the airway in this patient right now? First thing. Okay, I like your thinking, but so you're thinking that I'm probably going to have to intubate, but I don't know if I want to do it right now. Thank you. Okay. And what I want us to think about, right? GCS 8 intubate, maybe not right away, right? Oxygenate and ventilate. This is the slide for this talk. Oxygenate and ventilate. That's what you have to do, right? The rest is how are you going to get there, right? What do we need to do right now? And what are we going to need to do in order to continue oxygenating and ventilating? And I think in this patient, if they're taking their own respirations, getting some oxygen, maybe supporting them with a little bit of bag mask, right? Make sure there's not upper airway obstruction. And then make sure it's not a tension pneumothorax that's making them hypotensive. Make sure you have access. Give them some volume, right? This is the point, because what's going to happen if someone comes in shock and you rush to intubate them? I see a lot of people thumbs down, right? I guess that's what was this McCain thing, right? When, if someone's really hypovolemic, I think there's a certain amount of sympathetic tone, which is like their fingernails just hanging on. And if you take away that sympathetic tone with your induction agent and they don't have, right, the venous return, then you're going to lead to hemodynamic collapse and you precipitated a crisis. And I don't remember if I included that in this slideshow. I should have. But my themes, especially both for the surgery residents and for the EMS, my themes were oxygenate and ventilate, be prepared to escalate, and don't precipitate a crisis, okay? Whenever possible, right? If you can't oxygenate and you can't ventilate and the patient's in shock, well, F it, what are you gonna do? You gotta do 2 things at once. You gotta secure the airway. And we'll talk about how to at least mitigate those disasters, how to try not to precipitate a crisis. All right, so let's say we have this patient. Saw one recently similar to this. Actually, the guy that we saw was like 70. I don't know what he was doing. He like slipped off a stairwell and landed neck first onto some iron gate and had a penetrating like oral pharyngeal injury. He noted voice changes. He was sitting forward in his bed, and with the suction, he would spit out some blood. All right. How are we going to manage the airway in this patient? Who wants to, let's say he's stable, breath sounds are clear, you have access, hemodynamically stable. Who wants to induce and intubate right now? What's going to happen if you intubate? What's going to happen if you lay him down? He's going to aspirate on the blood, right? You've precipitated a crisis. You violated one of the tenets of Dr. Fitzgerald's trauma airway management. Okay. So what are we probably going to do in this patient? If let's say, sometimes we manage to get a CAT scan first or whatever, if it's not as severe as I'm describing, but there's oropharyngeal injury, even if they're more stable, what are we going to want to do? Yeah, this is somebody who actually, we're going to go to the OR, right? And what are we going to do in the OR that's different? And this is what I tell the EMS people, like, they have this skill set and they want to use it. And I'm telling them on a lot of these patients, don't do your skills, get them on the bus and get them off the street, because we have more capacity in the emergency department to deal with the crisis that we may precipitate, right? We have blood, we have teams of people, not just two people kneeling, on a street corner, right? We have the EMS or the ER residents and attendings who know how to intubate. We have anesthesia, we have glide scope, we have me, with a knife, we have more. And for this type of patient in the OR, what can we do that is much harder to do in your in the trauma bay? What's that? So surgical airway, what we would do with this patient is probably prep the neck and have a kit open, but what else can we do? What awake fiber optic intubation, right? If you're ever going to put anything, just as now I'm getting on a rant, a tangent. If you're going to try to put a bronchoscope through the cords on an awake patient, what do you want to do first? Lidocaine on the cords, thank you, right? That's how they killed Joan Rivers. They mess with their cords without giving lidocaine first. Don't precipitate a crisis, right? Pre-treat so you don't cause bronchospasm. So a lot of what I'm teaching you is don't rush to try to do the skills that you really want to practice, right? Oxygenate and ventilate first. Be prepared to escalate, prepare for escalation, and don't precipitate a crisis unnecessarily, all right? I know you want to intubate, but this one we're going to take to the OR and the patient is better for it. Let's say if it was, I messed up the series on this. I was supposed to have a question that led to intubation correctly. So let's just say it was one of these people that, right? Because the person who's in shock, not only this first patient, not only you want to bring the blood pressure up, but if the airway is not the problem, if you're able to oxygenate and ventilate, this is another one that we're going to want to take to the OR and take care of there. Why? Because if, despite our best efforts, we induce and he crumps hemodynamically and we have to open his chest, it's going to be a lot nicer to do that when we have the whole surgical kit there, anesthesia, the blood cooler. If we're prepared, if we're in the operating room, we have a better chance of success because we're prepared for that escalation. Let's see, do I have another one here before I come back to it? Okay. We use this scenario in different ways. Let's say there's isolated head trauma, poor mental status, hemodynamically stable, but he's statting in the 90s. How are you first gonna ignore that stuff underneath here? Ignore those second dots, just the first three dots. How do you want to begin to manage the airway in this patient? So put some oxygen on him. What else? Yeah, maybe bag him, right? You're going to want to look and make sure he's not a mouthful of vomit or blood, right? But barring those things, you can try to oxygenate him. Let's say we check the breath sounds are clear. We check, the circulatory exam. We have access. He's hemodynamically stable. And what are we probably going to want to do on this patient with isolated head trauma if he's hemodynamically stable? What's that? Yeah, we're probably not going to get anyone to intervene unless we get a CAT scan, right? So how are we going to make this patient safe for the scanner? Sounds like we probably have to intubate this patient, right? All right. So I don't know if I probably should have asked you guys what you like to use, right? I feel like, again, don't think too hard. Really, there are times where we have to think hard. But when you don't have to think hard, don't waste time and energy thinking. If you have a checklist, if you have a protocol, then you just run down that without thinking too hard, right? Is there one that you guys like to use to prepare for intubation? Is there a standard one you guys teach at all? I don't know if that's something to think about. I haven't landed on one. Again, there's probably people in this room who have intubated more than me, and definitely people who you know, day to day, month to month, year to year intubate more than I do. But basically, you know, there's different ways of thinking about it, but you have to be ready with everything that you're going to need, right? Have your suction ready, have your oxygen ready, have everything you need to intubate, have everything you need to escalate ready. I actually like what I've seen done when we get to oxygenation. I like having like two forms. If you have a nasal cannula and the bag mask, then when you take the bag mask away, you're still passively oxygenating, right? Might buy you a little bit more time on that patient that might be difficult. Positioning, right? What type of patient is positioning going to be really important? Obese patients, right? The ramp. I remember when I did on my fellowship, we had some anesthesia intensivists and I did a rotation with them just to like intubate more. And like I walked into a room and it was this obese patient just lying on the table. He like gave me the laryngoscope and said intubate. And it was really challenging. I don't know why he decided. I guess he's trying to teach me a lesson. Then he reached his arms underneath and propped the patient up and like auto ramped him. And then it was easy, right? If you just set the patient up to extend their neck and improve the anatomy, that helps with obese patients. But you have to think about it, right? That's part of getting ready, right? Plan what your approach is going to be. What's the position? Is it adequate? Are they falling off the bed and you have to move them? Pre-oxygenate, make sure you're ready for that. Part of your preparation is IV access, all your medications, all the equipment that you're going to need. Be prepared for the post-intubation stuff, right? The end tidal CO2 monitoring. What else? Be prepared for your backup, your escalation. Do you need a video laryngoscope? Do you need smarter, more experienced people in the room? Right? I know you guys probably hate it, but sometimes I'm like, let's call anesthesia. Even if they're standing there waiting, that's because of my rules of trauma airway, right? We're oxygenating and ventilating. I want to be prepared for the escalation, and I don't want to unnecessarily precipitate a crisis. And be prepared for that. As soon as you're done, be prepared for the after things. You have to check that you're in the right place. And we're probably going to need sedation. We're probably going to need things to move on to the next steps. So let's talk a little bit more about, I don't know if you guys have induction agents or medications, the neuromuscular blockade that you guys like to use. Any of these that on certain types of patients that we definitely don't want to use? Any medications there you want to say some patients never use? So crush and burn patients, right? And maybe certain spinal cord patients. We won't want to use the succinylcholine. What's the problem kind of across the board with the induction agents? We talked about it already. Hypotension, right? Probably with ketamine, there's a little bit less than other things. I know we teach with ketamine, it'll raise intraocular and intracerebral pressure. I've spoken to Michelle Feinberg about this, who's my favorite neurointensivist to talk to. She doesn't think that's really clinically that important. But I think what the bigger issue is that, again, don't precipitate a crisis unnecessarily. And I've talked to Budorax about this because whenever I give this talk to any talk to EMS where intubation comes up, they ask, what's the best, agent and regimen to use for the hypotensive trauma patient, right? Because that's the one we're all a little bit worried about. And I'm going to do another aside. Sorry, it's a little bit disorganized. Hope you guys are hanging with me a little bit. If you ever guys look and see where I stand when we're getting ready to intubate trauma patients, I almost always stand in one of two places. Do you guys know? In this head trauma patient or especially in the hypotensive gunshot wound to the abdomen patient, where am I standing? What? Foot of the bed. Why? Yeah, because we don't have an A-line down there. People are moving the patient and doing stuff. We lose the pulse ox. I'm the only one in the room that knows if the patient has a pulse or has gone into cardiac arrest, because I have my finger on the DP pulse when we induce anesthesia. I'm the first one to know if we've lost pulses, right? And there's things you can do, I don't know, volume or maybe a little push of epi or something. But first thing is recognize it, right? So the other patient who fell on neck first onto the fence, where am I going to stand? We'll get to that. All right. Yeah, right. So induction agents. What do we do with the hypotensive trauma patient whose main problem is hypovolemic or hemorrhagic shock. There are patients, right? There are times where we've intubated with the medications weren't ready and the patient was practically on death's door. We've intubated without medications, right? And there may be times where the patient has no mental status and we're furiously trying to resuscitate, where you may only give the paralytic and not give the induction agent. That's cruel if the patient has any capacity of any perception of what's going on. But there are patients in certain moments where that may be the safest thing to do. The other thing you can do for a patient who has, some awareness but is in profound shock, maybe give half dose, right? Maybe not give the full dose. Maybe that's a little bit safer in terms of making it not a cruel thing to intubate, but try not to precipitate the crisis of cardiac arrest. Anything else you guys who intubate a lot want to say about this slide?
When I started, we were doing sex on the phone a lot, except for the cases where it's now they're culture to switch to rapid for
Yeah.
It's not about the rapidly paralyzed.
Yeah, it takes a little bit longer, but yeah. Right, and again, there are people who do this more than me, but you want to know what you're looking at. The nice thing with the video laryngoscope, sometimes, even if it's not a better view, everyone else can see what you're seeing and give you some advice and feedback and make you better and make sure you see, what you're doing and visually confirm what you're doing, right? And what you want to see is, right, the cords. You want your airway to go between these cords and not posteriorly into the esophagus. I won't belabor that too much. Anything else about intubation? What we're talking about it right now before we move on? I think that's okay. Okay. Right, and you can get into all these things about, the different laryngoscopes and things, video laryngoscope. Other people can teach you that. I just want you guys to be prepared, to escalate and know what can precipitate a crisis and either try not to, or if you're compelled to, be prepared as much as possible to respond to it. Right, so let's say we had this isolated head trauma patient. We did all the stuff we just talked about. We put the ET tube in, and then patient's desaturating. We hook up the thing. There's no color change. We listen to breath sounds, right? Because that's what we do on every single patient, and we don't hear breath sounds. What's happened? We've intubated the esophagus, right? So what do you most likely? So what do? Well, you got to take it out. What's your next step? Bag mask, right? What are you trying to do? Goes back to the slide earlier, trying to oxygenate and ventilate, okay? Let's say you can't. You're not moving air well. Patient's not saturating well. Anything else maybe you could have done before you were in a crisis? Yeah, maybe try an oral airway. Try if the problem seems like it's the soft tissue in the mouth, maybe try to prop that open so you can bag mask effectively, right? You said nasopharyngeal airway, right? What if those things don't work? Patient's desaturating, can't oxygenate, can't ventilate. This is the little, I make a joke about some patients, I pull the fire alarm, but like this is the alarm that goes off in the back of my head, right? I'm like, I'm sure I drive people crazy sometimes, but I just want readback confirmation. Can we oxygenate and ventilate? And if you can, I'm calm and patient. And if you cannot, then I'm prepared to escalate. So what do you do with this patient? Head trauma, needs to be intubated, you induce, can't oxygenate, can't ventilate. All right, how do you do that? If there were 3 words you would say for a surgical airway, what are they? What was it? Scalpel, finger, bougie? Did you look at my slides beforehand? I took this from a Canadian EM critical care group. But right, this is the point, right? So what was I saying, right? Let's say the problem is not shock. The patient is hemodynamically stable. We think euvolemic, but the problem is like neck or face trauma, retropharyngeal edema. Where am I standing when you guys intubate? Anyone know? Anyone ever see me do this? I'm standing on the patient's right with my left hand, my first and third finger palpating their thyroid cartilage, and with my index finger, I'm palpating the cricothyroid membrane. And then maybe one other thing that I want to palpate in the neck. Anyone know? When I was a surgery resident, I was a chief resident, we had a patient, had this massive thyroid goiter that had surgery. He was in hospital for days and it was swollen, but he seemed to do fine. He went home, he lived in Queens. And then for whatever reason, one day, post-operative day 8 or 9, I don't know why, the edema got worse and he was having trouble swallowing secretions. They said, take him to the hospital. He's in Astoria. So they go to Mount Sinai, Queens, which doesn't have the same capacity as the main campus. And what did they try to do? They tried to intubate him. They couldn't intubate him. And then they weren't prepared for the crisis. And he basically died of anoxic brain injury. But the point, and then at M&M, the reason I bring up this story, sorry, it had nothing to do with that patient. But at M&M, the surgeon, the head of neck surgery was like, look, if you cut in the middle, and especially if you can feel the cartilage, it's better to have damaged cords on an alive patient than preserved cords on a cadaver, right? The only other thing that if you cut in the midline would be a huge problem, right? Most of the things you can hold pressure. If the anterior jugular vein bleeds, you can hold pressure. If the thyroid tissue bleeds, you can hold pressure. One thing that's not going to be so easy to control is the innominate artery, right? Some people have a high innominate. If you ever find yourself in a position where you're doing a surgical airway, just check to see if there's a pulse right here above the what do you call this? The sternal notch, right? Because, it'd be a shame to not notice that and then cause arterial bleeding, into the airway, right? So here's a picture of the anatomy, and just this isn't the perfect slide because it actually shows right where we do tracheostomy, which is different than cricothyrotomy. Cricothyrotomy is here, right between the thyroid cartilage and the cricoid cartilage. Is a little soft spot there, right? The ideal place for doing a surgical airway when we have time and anesthesia is between the first and second, or the second and third tracheal cartilaginous rings. That's what this shows. But almost always when I've had to do a surgical airway, and I've had to do it about once a year at Kings County, almost always I can't see the anatomy. The reason why I'm doing it is because the anatomy is difficult. I'm doing it based on feel. I'm cutting in the middle until there's some air, bougie, right? So I'm not looking in between where's the second and third cartilaginous ring. So that's the difference. People talk about a slash trach, but in my experience, when I have to do emergency surgical airway, I don't have the appreciation of the anatomy or the time to do some dissection to see it. And so I'm aiming for the easiest target that has, good outcomes in terms of complications, which is the cricothyroid membrane. And again, I like to stand on the patient's right. I'm right-handed. My left hand is confirming the anatomy, feeling the thyroid cartilage, palpating the cricothyroid membrane, making sure the innominate isn't going to get in the way. And I cut in the midline until I get some air, and then bougie, ET tube, or better yet, tracheostomy. But usually I'm getting stuff handed to me from the top of the bed where they failed to intubate in this kind of scenario. So let's say we put the ET tube in place after you've done your emergent cricothyrotomy. What's the next thing you're going to do? You're going to blow up the balloon, and you're going to confirm, you're going to listen to both breath sounds, and what's going to be missing? The breath sounds on the left are going to be missing, because I promise you, if you don't do this often and somebody gives you, an 18-centimeter tube or whatever that you're used to putting down, I mean, more than that, whatever, 30-centimeter tube that you're used to putting to 22 centimeters, when all you need to do is make the balloon disappear beyond the cartilage, you're going to put it too far. So check, it's too far, pull it back until the balloon's right in place, and then you can secure it with the soft tissue around it and check and confirm. And I like to, often I make a big cut and then I suture the tissues closed a little bit around it, maybe that tamponade, some of the soft tissue bleeding, and then, tie it around the tube. And that should be safe enough to get your imaging, even go to the operating room if neurosurgery has to. And it can be revised, but there's some data that they don't even the benefit of revising it to a formal tracheostomy isn't always so clear. So that's the money part of the thing. What is it, a half an hour talk? All right. Yeah, I guess I had one case that was a little bit similar to this, where the gunshot was retropharyngeal and the patient was fine until they weren't. And we actually, I think we might have tried to intubate in the ED, couldn't intubate, but we're able to oxygenate and ventilate. They ended up putting in an oral pharyngeal airway, tried awake bronchoscopic, couldn't get it. And that patient, we actually did a tracheostomy in the operating room because we were able to oxygenate and ventilate for 2 minutes for me to identify the anatomy and do a little bit better surgery. And that's obviously better in the OR than in the ED. Any of you guys ever had an airway, can't oxygenate, can't ventilate, can't intubate on a child? On an infant? My least favorite, I have codes that I don't like at Kings County. I don't like code heart, because really what you should do is put them in a wheelchair and across the street or something and call 911. I don't like a trauma code to LND, right? Because they're all young women who are supposed to do fine, who are about to die until we get there. I'm glad that they called me, but still that raises my blood pressure. The other one I don't like is the series of pages to the emergency, to the pediatric emergency room, which is ENT, anesthesia, and then like code 88 or code 99. Sometimes I even respond to those. So what do you do in an infant? Can't oxygenate, can't ventilate, can't intubate. I've never had to do this, thank God. They describe a needle crike, but it's really not a good airway. We don't have the jet ventilation that you could use with it. You can maybe, you know, get a 3cc syringe and connect to the thing and bag, but that's really only going to be long enough to do a tracheostomy, which you'd have to do in real time in the ED probably, because that's not a secure airway. But whenever I show up to those 3 codes that I don't want to hear, like the ENT, anesthesia, code 88 or whatever, I just ask someone get me the largest angiocath that you can find. And if they can't oxygenate, can't ventilate, can't intubate, then I'll try to put the little angiocath into the cricothyroid membrane and buy us some time to keep the kid alive. This is a little bit more for the surgery people. But you guys we're almost out of time. I'm over time. Can I take 2 more minutes? Yeah. You guys are going to be in the SICU, right? It's your first night in SICU, and Dr. Fitzgerald just did a what do you call it? A percutaneous tracheostomy, and you're just walking around trying to figure out what's going on with the patients, and you see the respiratory therapist fiddling with the thing, and the alarms are high airway pressures, inspiratory and expiratory volumes aren't matching. What should your immediate thought be on this fresh tracheostomy? Right? High peak airway pressures, inspiratory and expiratory volume mismatch is because there's a dislodged trach. Absolutely. Sometimes that's not the problem, but again, be prepared for escalation. And it may be that the crisis is already precipitated. The least you could do is recognize it. So it's worth knowing when there's a trach dislodge, is it old or new? A trach after a week, or especially 2 weeks, a tract is formed, and usually there's like a fistula, and it's not as precarious, right? It's worth knowing, is this a laryngectomy patient whose airway doesn't connect to the mouth, or is it just a surgical tracheostomy, right? In this fresh tracheostomy that you're getting those airway alarms, right? Some people may try to pass the suction to see if it goes in, especially if you can't pass the suction. What should you do in that circumstance? You're alone in the SICU. Do you try to remember Dr. Fitzgerald's number? Trauma code is not a bad idea. Yeah, I was going to say code 88, but you're right. A trauma code is better because we'll show up. Basically, it's a lonely place to be when you have an airway emergency by yourself, particularly if it's surgical anatomy that you're not familiar with because you don't cut into the neck. So you want to call your friends, and that's when you pull the fire alarm, and hopefully all of your friends show up. Because often what you're going to want to do if the trach is really out, rather than push it back in, which is people's inclination, sometimes the best thing to do is hold the finger over the hole in the neck and bag mask from above. If you can oxygenate and ventilate, then you can get your friends there, and then you can re-intubate, then you can go to the OR, then you can revise the tracheostomy. If you're trying to force it in blindly, you're likely to put it in a false tract, and that's not going to be able to oxygenate or ventilate the patient. And if you're doing that instead of calling for help, you're wasting time and increasing the risk of anoxic brain injury. I think that's all that I have today. Thank you. Hope that was useful.